So thank you, Brian, and good morning. I'm Bleddyn Rees, and I'm the moderator for this next session, which is telemedicine and connected health. AI, blockchain, chatbots, personalized apps are among the advances in technology being utilized to transform healthcare. This morning, you're going to hear from experts at the front line of the healthcare revolution and hear about the innovative work making a real difference in the lives of patients. I'm sure many of you will have seen Christian Eriksen and the heart attack that he had on the football field. And some of you will know that what saved his life was a defibrillator. What many of you will not know is that the defibrillator was invented in Belfast and Northern Ireland. So it's very fitting that this morning we should be coming to you from Belfast. So the pandemic has accelerated much adoption, virtual GP and outpatient appointments. But the interest in the R number and health data and predictive models and AI has also taken off. This is the perfect backdrop for this session. Introductions. First of all, we've got Professor Rachel Dunscombe, the CEO of the Nhs Digital Academy, an advisor to the Secretary of State in the United Kingdom. A digital and IT expert, substantial hands-on experience at the Royal Salford Hospital, extending to community and social care. Passionate about AI and health, and the health representative of the UK on the AI Council. Second, Thomas Gornak, founder of and CEO of Better and co-chair of the Open EHR Foundation, a 30-year veteran of world-class software development, and who at Better has done some amazing work, which I'm sure he's going to talk to you about in Russia and South America, to name but two. And then finally, Liz Ashall-Payne, the founder and CEO and also of Orca, as well as being the vice chair for standards for the British computing industry. A mission to unlock health assessment and distribution services in 11 countries. Award-winning missionary work. Liz is a clinician by background and a digital health entrepreneur. After each of them have presented, we'll have a question and answer session. So now, without further ado, I'll hand over to Rachel. Thank you.
Thank you, Bleddyn. And I'm going to talk a little bit about the Nhs Digital Academy, which indeed provides the senior leaders in the NHS in England, Northern Ireland, Scotland and Wales for all of our NHS organisations. So skills are going to be the rate limiting factor for transformational change in our healthcare systems. And within the UK, this has been a journey and a learning that we've been on. So I just want to go back, first of all, to the NHS's constitution, the constitution of the health system that is very similar to the aims of other social healthcare systems across the globe. Our constitution says that we're going to work at the limits of science with the highest levels of human knowledge and skill, and that we're going to serve our patients and public. So they're very important words, because the limits of science and the highest levels of human knowledge and skill are about bringing digital to actually benefit our populations that we serve. Now, when these words were written here by Nye Bevan, that would have been, 1940s. Those words would have meant medicines. They would have meant, early X-rays, but these words now mean digital health technologies. And this is something we take very seriously in the Academy, and we teach people how to actually manage the opportunity around digital health and make sure we leverage it appropriately. So to talk about the digital skills emergency, as I said, we have found that skills are the rate limiting factor, and the Academy that I lead provides leadership. They go through either a PDIP or an MSc program from Imperial, Edinburgh and Harvard. And 125 of these great leaders every year are going into the system to actually lead transformational change and to make sure that we are leveraging that opportunity of digital within our healthcare systems. Not only are they doing, AI, not only are they doing data science, not only are they doing co-design with patients, they're also working out how to make the economic case, the social case, they're learning about ethics, and many of them are actually clinicians as well. So it's the most wonderful place for us to progress the science of digital health within the NHS. Why did this happen? Well, we've had a lead-in of about 5-6 years to where we sit today. The first thing that happened was the WACT review. wonderful doctor called Bob Wachter from the US, who is also a professor, who undertook a review for Jeremy Hunt of where our healthcare system was. And he made 10 recommendations, but with a backdrop of skills. And he was the first person that drew attention to the fact that leadership and skills were going to become the rate limiting factor for transformational change. I put a link there to the Wachter review. It's well worth looking at for all healthcare systems globally. Following this, we had the Topple review. And again, I was lucky enough to be part of this. This is a really great report if you take a look, because it looks at the future careers. It looks at what clinicians will be doing, what technologies they will use, how their working day will change. And it has some very beautiful vignettes of future careers. And this has been very important for us because it focuses both on the new role of the patient and how we include the patient, the role of the clinician and how we use technology to free up their time and give them a more caring experience for their patients. And it also shows us how we can actually develop our workforce towards the future. So the Topple review is another sort of guiding light towards what we have done. Just want to share with you a little bit about the journey actually that everyone goes on within the Academy, because I think it's quite important to understand what we do. Firstly, we look at health systems. Many people don't understand the system they sit within. So health economics, how money flows, how things are commissioned, how to make economic cases. We then look at governance. We look at innovation and commerce, commercial models within Module 2. Module 3, we look at health systems and technology, so all of the standards in health technology. Module 4 is user-centered design and citizen-driven informatics, and very much here people co-design with patients. It's very hands-on, in particular from this module onwards. Then module 5 is decision support, knowledge management, and AI. Again, people get very hands-on and learn a lot about AI, not just the very technical bits, but also the ethics and the governance. And then the final part is developing each and every leader that we have within our system to make them one of our future leaders for the NHS. So I'm really proud of what we've done in the UK. This has been evaluated by the NHS as being something that is part of the future, and it's been enhanced in its commissioning. And I would welcome you on any of the Twitter handles we've got here to reach out if you do want to know more about digital health education. But certainly, we hope that we're leading the world in actually taking digital health education to leverage the opportunities that these technologies can bring for humanity. Thanks, Bladen.
Rachel, thank you very much indeed. Fascinating. And that's setting the scene for everything else we're going to talk about in this session. So if I can ask Thomas if he would now present. Thank you.
Hi, thank you, Bladen. Rachel talked about an important aspect and a prerequisite to actually digitizing healthcare. And I think the second one is data, and that's what I'd like to talk about. So we see several trends that have been accelerated by COVID, and I'm sure you're familiar with the fact that healthcare is shifting from hospitals to communities to the home, that citizens want to be more engaged and they're demanding access, not asking for it, but demanding access to their health record. And of course, that COVID gives us opportunities to really change the care delivery. So on the other hand, we have existing systems. And I really like this quote by the head of strategy for Catalonia, where he says that basically we've been trying to do interoperability for the last 25 years. Unfortunately, it's not working. And the only way that the data follows the patient today is if he carries it around in a box in paper form. So there is a big need to do things differently, and I'll try to show you what can be done. On the other hand, governments, in this case, the UK, has started to talk about the issue of data lock-in by the vendors, having data in systems that are struggling to share this data, and how that is a barrier to research and innovation. And Matt Hancock goes on to say that the solution to this is to separate data from applications, and even talks about a consistent data platform across the NHS. And this was recent, and I would like to think that it's really the result of the learnings from COVID, and how not enough data was available to make good decisions because it's locked into disparate systems. So let's talk about data. This is a quote from a research paper that Rachel did with UI, but I really like the word data for life, because it's not only that data is necessary for performing healthcare, but it also has to stay there for the lifetime of the patient. Having access to data, even from birth, is important throughout your lifetime when you're trying to get care. So the way to do this is, as Matt Hancock said, to separate data from applications. So instead of building it like we have up to now on the right, where we have data applications and logic grouped together in silos, the idea is to move the data to the center, to provide a vendor-neutral data core, and to build applications, algorithms, connect devices around that core, but to a consistent patient record. Now, this is all very recent. This was published last year, and it was followed by the Gartner Group report research, which actually talks about exactly the same thing: a data repository, an application inventory, and then a user interface on top of that, layered out instead of in silos. So this concept is not new in healthcare. If you think about it, the imaging industry, the PACS, have been doing this for 30 years. DICOM is a vendor-neutral format, and every modality knows how to write, and every application knows how to read DICOM images. PDF is very similar, but unfortunately, the structured data, the data we depend on for what we're talking about today, which is AI and telemedicine and chatbots and so on, that data is still locked in the applications that produce the data. So this needs to be taken out. And an organization working very hard to make this happen is called OpenEHR. It provides vendor-neutral specifications on how to manage clinical data outside of the application, separate from the code. So it's really taken off in the last few years. We now have over 100 countries involved, 1,500 clinicians who have built models, and all of these clinical data models are free to use. You see some of the countries that are most active depicted by the size of the flag. So where do we begin? So obviously healthcare has a lot of legacy. And it's not only the legacy that we think of as the core system, it's also a lot of other applications, a lot of other systems which have been built through the years. There's trusts in the UK that claim they have thousands of applications. So how do we solve this problem when we move to this new architecture? So the idea is to, when you're about to build the next new application or app, build it on top of this new architecture, a vendor-neutral data platform. And as you move some of the data from the legacy system, you keep adding applications which work very differently. They do not store their own data. So you are not replicating the problem you had previously when you're building this new ecosystem, as we call it. And you end up with, through time, in what we call bimodal world, where you have the old legacy running, but at the same time, you have an innovation platform where you can quickly innovate without hiding the data in a particular application, having a consistent longitudinal data for life record of patient data. Okay, so if we move outside of the institution into a region, some things like the ICSs in the UK, but cities or states in the rest of Europe, we see that we can do the same thing. We can normalize data on premise and then start querying this data. As long as it's on using the same data models, we can create a virtual patient record, even if we don't centralize the data. But the whole concept is based around the one patient, one record. And you can see the value of this if you're trying to build algorithms, use AI, of having consistent, high quality, validated data to build these algorithms. So the other idea here is that if you build to this model, you can actually start sharing applications because they are pre-integrated to the data models, which are shared by the institutions. Now, in some cases, of course, it makes sense to centralize. This is an optimization, which actually logically means exactly the same. But of course, it's a little bit more efficient if you can do that. Some countries can, some cannot. Now, we as a company are very proud that Gartner has selected us and put us on this slide of having a digital health platform as defined by Gartner among a group of obviously very large companies. Now, who is leading? I'll finish with some use cases. So the largest system currently is Moscow City, who has built a centralized patient record for all 12 million citizens. And you can imagine how handy that came when COVID struck. They were able to quickly centralize testing, vaccinations, make decisions based on a consistent care record. Obviously, they're using this approach, which I talked about before, a centralized one. On the other hand, we have 8 leading German university hospitals, which are connecting data they need for research, normalizing it on premise, and then sharing it through querying, and they're using this approach. And these are all the largest German university hospitals who are involved in this initiative. So another aspect is, of course, the vendors. And I said in the beginning that the vendors are locking data in. Well, the most advanced vendors like the Nordics, all 4 of the leading vendors in Sweden, Norway, and Finland are actually adopting OpenEHR and offering open data to their customers. So this is quite unique. Obviously, the Nordics are quite advanced in healthcare IT, and it's really refreshing to see this different approach. In the NHS, it's really ramping up. So there's over 30 NHS trusts who are doing this now. Wales was the most recent example, which is basing the National Data Resource Program on this open data concept. And finally, just recently this year, the Catalan Health Service announced they will base all their standardize their health data on OpenEHR for the entire healthcare system. This is going to be a really interesting project to be done in the next few years. Okay, I will just summarize. Obviously, the current systems are impeding digital transformation. Data is for life. Applications will not last that long because they need to be changed every so often. So we need to separate the two. Digital health platforms offer 3 things: personalized UX, low-code tools to quickly build applications, and a vendor-neutral data repository. And OpenEHR is now widely used by the most advanced health systems. So with that, I'd like to thank you and turn it back to Bledin.
Thomas, thank you very much indeed. And so we've been through digital skills to data and a platform, and we now move back to looking at digital health assessment and distribution services. So Liz, over to you.
Thank you so much, Bledin, and thank you for inviting me today. It's a real pleasure to be here. So I'm going to talk about how we can support the digital citizen or the digital patient through digital health solutions, being apps or web-based products. So the first thing just to say is that we currently have access to over 370,000 digital health solutions. And every day, what's been fascinating to track is the number of these products that are being downloaded on a day-to-day basis since the start of COVID. So every day now, 5 million people will download a health app, and that's increased by 25% since the start of COVID. And what that's telling us is that people are looking to digital health to support them and their loved ones with their health or a health condition they may be living with. What we're also seeing is that healthcare providers and policymakers and ecosystems are really seeing the opportunity. So we've already heard there about policymakers and the direction of travel, but healthcare professionals who are on front line are also seeing the opportunity that these tools have in supporting their patients. So over 90% believe that these products can improve patients' health, and over 80% of healthcare professionals are already using these solutions in practice. So that gives us a real indication that this is an ecosystem that is being used by our citizens, embraced by our healthcare professionals, and policy, including the World Health Organization, are really pushing for activation of these products. However, there's a really big challenge in this space. There are lots of challenges, but the ultimate challenge is which ones can you trust? So of that huge volume of digital health solutions available to us, how do you know which ones are safe, effective and suited to your patient? Our research at Orca has found that only 20% of the landscape of digital health meets standards and regulations, which means that for those 5 million people every day that are downloading a solution, most of them are downloading unsafe and unregulated products. Now, just imagine if that was the same for the world of medication. And Orca has been created to try and make sense of this landscape, to help people find and use high quality digital health. And because trust is the biggest barrier, you have to start with that. How do we start to build trust in this confusing landscape? Well, if we just start by looking at the regulations out there available to us, there are lots and lots of regulations, standards, best practice and policy guides around what good looks like. But it is a regulatory puzzle. And the reason it's a puzzle is because there are lots and lots of standards in 4 big domain areas. And the first question is, well, which of these standards and regulations should be applied to the product? Because in the world of digital health, we have some solutions that are very simple, for example, digital recipe books. And at the opposite end of the spectrum, we have digital health solutions that interoperate within clinical environments, that are built on clinical algorithms, that are medical devices. So you can't assess and evaluate products in the same way. So the first challenge is which of these regulations in these 4 domain areas, data privacy, data security, clinical assurance and user experience, need to be applied. The second challenge in this area is new regulations are emerging all the time. So we've just heard about Thomas's work, and we're starting to see new regulations emerge around interoperability, authentication, consent, verification, etc. So this is not a static landscape. And the third big challenge is that the product or the digital health solution itself will keep changing and updating. And we want that to happen because it's responding to user and feedback from the health and care system. But how do we manage that as a process and a system to build trust? Well, what we've been doing at Orca for the last 6 years, both here in the UK, but also across Europe, North America, the Middle East and Australasia, is we've aggregated the duplicated effort across all jurisdictions. And what we've built is a foundation or a baseline review process. Now, the answers to these questions are answers that everybody on the planet wants to know the answers to across those 4 key domain areas. And it's run by people and experts, but we use technology, which means that we're able to use a technological platform that allows us to only apply regulations and standards in a proportionate way to the product that's being assessed, and really importantly, repeatedly, so that every time the product updates and changes, the process of review is undertaken with any changes that have emerged. Now, the reason this is a foundation level is because there are differences depending on where you're working in the world. So you can see here across the horizontal area, the Orca baseline assessment, and everybody's using that as the answers to that question as a foundation layer to the standard that they have in their country. Now, here in the UK, in the NHS in England, and we have the Nhs DTAC, which is the 4th vertical. And you can see that on top of that Orca baseline review, there are some very, very specific criteria, for example, around clinical safety, and a standard that's very specific to the NHS called DCB 0129 that is very relevant within the NHS. However, other jurisdictions wouldn't necessarily need to know the answer to that question. Now, what this means is that as an organisation that assesses and evaluates products, we only have to do the bulk of the questions once, and then we're able to talk to the innovator community to let them know what good looks like in the other verticals. And therefore, there's real economies of scale, and we can all learn what good looks like collectively. Now, obviously, knowing which products to trust is critical. But what we're really obsessed with is helping improve the lives of people and patients. So once you know which solutions are great and meet quality standards, you then need to tell people which solutions are good. Now, the way in which we do that is we work with partners, healthcare providers, healthcare payers, and other organisations working in the digital health space to create digital health libraries that get promoted in a very targeted way to specific populations. And what this does is this reduces the opportunity gap that we currently have, where people can now go to a trusted environment and search and find a list of high quality tools. They can then also filter according to their personal preference and need. So it's not enough to know which products are good. We also need to share with people how to search and filter according to their own personal preferences and needs. So for example, if we have a teenager versus an adult versus an elderly person, all living with the same health need or condition, it's highly likely that they're going to need a different intervention. So these digital health libraries are highly configured search engines with a highly sophisticated filter option. But that isn't enough. What we know is that the people who are interested in using digital health are probably already activated to look after their health and are probably already interested in digital health. So how do we activate our unactivated communities? And this is really key. We have to work with healthcare professionals who have touch points with those communities. Because if a healthcare professional recommends something to us as patients, we are 70% more likely to do that job. What that means is we now have on the library side a formulary. And the formulary allows, first of all, healthcare professionals to be trained in digital health and then use this platform to recommend or prescribe via text message. Just very quickly, I wanted to share some of the data that's coming out of these platforms. So since the start of COVID last March, we started to see significant changes in what people were searching for, and you can see how that was changed over the course of the year. And then more recently, we've started to see a significant demand for digital health solutions to support long COVID symptoms. And you can see on this heat map that as the time progresses, the more intense those searches are. And what we've also seen as a consequence is that digital health innovators are responding to that need. And in the bottom graph, you can see that there's been a significant increase in products being available to support long COVID. So I'm really looking forward to discussion, and I will hand back to Blevin.
Liz, thank you very much. Fascinating to hear all about how digital health is being unlocked by Orca. So this leads us to the question session. So my first question to all three of you is: technology has promised to revolutionize healthcare for patients and for staff for perhaps the last 100 years. And I can remember seeing some funny slides about the invention of the radio and how that was going to transform access to GPs and outpatients. From everything then to the invention of the computer, to the IoT, and to AI more recently. So is healthcare, in your view, a technology laggard? And if so, what should we be doing about it? So who's going to jump in first?
Well, I go first on that, Blevin. That's a really interesting question. Are we a laggard? We should not be at the absolute bleeding edge of every technology, because that risk opportunity balance and the safety that Liz has talked about. But what I would say is that health is a very complex business, and this is about changing how people do their jobs. This is about changing how our patients work. And this is one of the most complex system conundrums we have in terms of how we change. It's all about people before technology. It's all about our clinicians, our patients. And so we are not going to move at the pace of, say, retail. We're not perhaps even going to move at the pace of banking. But when we do move, there are much bigger prizes, because the prizes here are about improving lives and saving lives. And so I think we are seeing now what I'd say is a consistent, well-led pace of technological uptake, particularly with COVID. We've proved we can do it during COVID. But I would never expect us to be at the pace of some other industries, and rightly so. That's my view.
I would just add that historically investment in technology, I mean, if we're talking about IT technology, has been low for healthcare compared to other industries. So there is a backlog of things that need to be adopted. It's now obviously increasing, in some cases a lot due to COVID. But I think that's one of the reasons, definitely. The other one is what Rachel said. We don't need to be bleeding edge, obviously, in this case. But I would argue also that, I come from telecoms and finance, and it is much harder than it looks, healthcare itself, in terms of IT. There's, you think that you could adopt technology from other industries directly, and you see that there's so many dimensions to using it in health that it makes it just so much more difficult. And just to correct you, Bledin, it's 140 years since the Lancet published that the phone could be used to reduce primary care visits.
Liz.
I was just going to just add one other thing. Completely agree with what's been said. Obviously, one of the things that we need to make sure with any intervention within a healthcare context is the evidence is there, and it takes time to build evidence. And in an innovative, fast-paced environment such as digital, it's going to take time. Most drugs take 17 years to get to market because they're building the evidence of impact. And quite rightly so, we are risk averse as healthcare systems, because we're not just talking about an impact on, say, a revenue, we're talking about an impact on people's lives. And so we do need the time to build the evidence.
Yeah, and that's a great point, isn't it, for all the startups and the small SMEs out there that are looking to innovate in healthcare. The fact that evidence is really important. And perhaps one of the things that we're all trying to do is to allow those startups and entrepreneurs greater access to the system to be able to actually generate that evidence. So if I move us on to the second question, which is from a patient perspective, which technologies are most exciting you right now? So Liz, do you want to start?
Yeah, I'm really happy to. So I think it's interesting. I mean, I shared some of the data around which areas are being most viewed and downloaded and recommended. And the biggest area by a significant mile is around mental health. Now, mental health has always been a hot topic because our capacity to be able to deliver to meet the demand of our populations has always been disconnected. And what we know since COVID and the pandemic is that mental health need has significantly risen. And I think that one of the things that we want to be able to do is get digital health solutions to support people who are experiencing mental health. And where we've seen even more significant rise is around our teenage populations who are digital millennials and ready to embrace these technologies. Obviously, I'm going to say this, this is about high quality digital health solutions, not just throwing technology at things. But as Rachel said, we do need to then think carefully about our systems and processes. And just finally, the other areas around diagnostics. So we've got a huge backlog of patients needing diagnostics, and we can use amazing digital health interventions to support that backlog if we know which ones are safe. Thanks.
Thomas?
Yeah, I mean, just the ability to have a lot more data from devices, I think, is a game changer, because it's really hard to get feedback in healthcare. And of course, the body can give this feedback using wearables, continuous monitoring, and so on. And we can close the loop on what effect a certain procedure or treatment has on the patient. Now, of course, there's still a long way to go, but I think just this feedback loop is what I'm most excited about.
Great. Rachel.
I like the personalization of experience to motivate people to engage. I think what we're seeing here is sort of a recognition that one size does not fit all, and we don't care by rote in future. And I'm seeing digital health solutions that enable patients to participate in the way that is best for them. Been involved, in a couple of pathways where that's happened, and different age groups, different demographics have had different interventions in terms of an experience. So for me, I think that this move towards, individual participation, which then means that you can lift some of the weight from the system, or certain demographics can move the weight from the system by self-caring and self-managing. That's starting to become a reality, and that for me is very exciting, because it means our effort can be put with people that really need our effort, as opposed to seeing everyone on a regular basis when they could self-care and self-manage.
Thank you. So pharma, technology, medtech, telcos or telecommunications, all global industries, yet healthcare remains national. Do we think that that's the barrier to innovation crossing borders? And I mean, interestingly, all three of you have given examples in your presentation about international innovation and examples. But how do we tackle this problem that innovation seems to be slow to cross borders?
I can have a go at that. Obviously, the payment systems are national, right? So and they're very different. If you want to have the adoption of innovation, you need to adapt the payment systems, the financing. We see time and time again great innovation not being able to break through. Insurance in the US, out of pocket covers a lot more than in Europe, but in Europe, people actually expect the healthcare system to provide for payments. And I think this is very fragmented across, obviously, Europe. So I see that as a major barrier to have pan-European success with digital innovation.
Right.
A couple of interesting things to me, actually, reflecting on what Tomasz said about converging on, standardized data, and also what Liz said about 17 years to on medicine. As we standardize our data and our approaches, we can create real world evidence. And I was very lucky to be involved in the Salford Lung study, which, was one of the first on the planet to take real world evidence. But now what I'm seeing is that learning health systems across the globe, as they share standards, can work together. I'm seeing, Australian institutions work with UK institutions, German with UK. And so what I'm seeing here, I think, is a possibility, and we need this, because with rare diseases and cancers, the groups that we are going to be dealing with a common genome will be smaller and smaller, and there will be a global cohort potentially that will want to work together with life sciences or pharma. So for me, I think that speed to evidence, the speed to access of real world data, and an agility of our healthcare systems is coming, but it does rely on data, and it does rely on international collaboration in a way which is conducive for disease groups.
Okay. Really great points. I mean, I was going to say it's about sharing, and the biggest challenge that we have is people aren't aware of what exists, and so we have to get better at sharing and having organisations and repositories of information that we can share access and awareness with.
Yeah, great. And a snap question to end our session. Bearing in mind all the knowledge that the three of you have about health technologies and what's good and where it comes from, which country do you think is the most innovative in healthcare?
Oof. Healthcare IT, you mean? I mean, the digitalization.
However you want to interpret it. Yeah, however you want to interpret it. Or
So
if you were ill, which country would you want to be treated in?
Oh, there are two different answers, I think, for me, Bladen. I would say most definitely Europe and the UK would be where I prefer to be treated, because I've had very good treatment in European countries and the UK. I am absolutely biased, but I believe that in the UK we are growing a cohort of digital health talent that nowhere else in the world has, and that will come to fruition over a number of years. And I'm very proud of that. So I would say the UK on that basis.
Yeah, I would agree. I think you have to think about whether it's cross-nation or pockets of innovation, and that changes things quite a lot. In terms of doing everything for the entire population, I think the Nordics are quite advanced. But of course, if you're looking at a specific hospital, and you can find them all across Europe, I think Karolinska was just named top 10 in the world just recently in digitalization. And I've been there, I've seen what they did with the new hospital, and it is leading edge.
Yeah, just quickly. So my answer is it depends on the clinical area and the area of technology we're talking about. I see amazing innovations happening in lots of different countries, even in areas such as third world countries like Africa, because they don't have some of the barriers to adoption around infrastructure. But like Thomas says, the Nordics, I think here in the UK, we've been driving this for a long time, and as Rachel said, will be coming to fruition soon.
Thank you. And for the ECH Alliance, I think we would absolutely agree with that, Liz, in the sense that we find best practice in some strange places where you would never think it is. And the point is, no one has a monopoly of good ideas and innovation. So I am being privileged to chair the three of you. Thank you very much indeed. And I wish the conference the best of good fortune for the rest of the day. And with that, I'm going to hand back to the studio. Thank you.
Thank you.